Hello and welcome to Sleep Review's webinar, Managing the Epidemic of Obstructive and Central Sleep Apnea in Cardiology. Sleep Review is pleased to be here with two esteemed speakers, Lee R. Goldberg, MD, MPH, and Alan Schwartz, MD. After the presentations, we'll answer your questions. Submit questions anytime via the Q&A box on your screen. We also have the advanced questions submitted on the webinar registration screen. So when we get to the Q&A segment, we'll lead with those. The slide deck is available for PDF download in the handout section of your control panel. Also in the handout section is a resources handout, which includes peer-reviewed studies and links to other resources that may be of interest. This program is brought to you by Itamar Medical and Respicardia. Both companies share a common mission of growing the awareness, testing, and treatment of sleep disorders, with a special focus on the cardiology patient population. For a certificate of attendance, which is available for the live webinar only, you must meet a few criteria. You must watch the webinar on its original air date of April 30th at about 11 a.m. Pacific time for at least 60 minutes. You must complete the course evaluation, which will appear on your screen at the end of the webinar or when you personally leave the event, whichever is earlier. Even if you don't have a need for a certificate, we'd appreciate it if you give us your feedback via the evaluation. If you are watching as a team, you need to register each person individually if each team member wants their own certificate. Everyone who meets these criteria will receive a certificate in their email within the next 30 days. For AAST members only, we will also submit your one continuing education credit directly to AAST. If you do not get a certificate within 30 days and you think you met the criteria, you can email sroy@medcore.com. Today's webinar is being recorded and you will receive an email tomorrow with a link to the recording. It will also be available for new registrants to watch on GoToWebinar for the next 3 months, but the recorded version isn't eligible for a certificate of attendance. I am now pleased to introduce Lee R. Goldberg, MD, MPH, FACC, FAHA, who is a professor of medicine at the University of Pennsylvania School of Medicine in Philadelphia, Pennsylvania. He is chief of the Advanced Heart Failure and Transplant section in the Division of Cardiovascular Medicine. He is Vice Chair of Medicine for Informatics at the University of Pennsylvania, and in this role is responsible for the implementation and optimization of the electronic medical record, as well as coordinating quality and operational data across the Department of Medicine. Dr. Goldberg is board certified and re-certified in internal medicine, cardiovascular disease, and advanced heart failure and cardiac transplant. He is currently a co-PI of an NIH-sponsored R01 grant studying behavioral economics as part of heart failure remote monitoring. Welcome, Dr. Goldberg.
Thank you very much for inviting me. It is my honor to present information around sleep apnea and cardiovascular disease. And the topic of my talk today will be sleep apnea hurts hearts. Are we screening enough? So to start at the beginning, cardiovascular disease and fatigue really go hand in hand. And despite maximal medical therapy, many patients continue to complain of significant fatigue. This fatigue can be multifactorial. It can be associated with a low cardiac index due to heart failure. It could be associated with medication side effects like beta blockers and other meds. It could be associated with depression, which is relatively common in patients with cardiovascular disease and stroke. Or it could be related to coexistent medical problems like thyroid disease or some of the other comorbidities that our patients experience when they develop cardiovascular disease. But at the bottom of the slide, sleep disorders is certainly one of the things that may be impacting fatigue of patients. And the question is, why is this important, or why do cardiovascular consultants really care about this? And that's because fatigue may limit the use of medications shown to improve cardiovascular outcomes, both morbidity and mortality. In this case, I'm highlighting beta blockers, although there are certainly other medications that would also fall into this category. By limiting beta blocker use, we prevent patients from obtaining the mortality benefit of this class of drugs. For example, in heart failure patients, the reduction in mortality can be more than 30%. And so not using a beta blocker till its full potential can prevent patients from getting that benefit. We also know that sleep disordered breathing is associated with depression, and depression itself impacts cardiovascular outcomes. Patients are less likely to take their medicines, less likely to exercise, and follow lifestyle changes when they're depressed. And depression likely also causes neurohormonal changes that also negatively impact cardiovascular health. We also know that sleep-disordered breathing itself impacts quality and probably quantity of life. And so when we ascertain that someone perhaps died of cardiovascular disease, the question is, was there a contribution from sleep-disordered breathing? And maybe that the two diseases together are driving mortality. And then finally, improvement of sleep, we know, impacts the adrenergic system in a positive way. And we know, I'll show you in a few seconds, that the adrenergic nervous system is associated with arrhythmias, myocardial infarction, and heart failure. And that's why there's been a significant increase interest in sleep by cardiovascular clinicians. This disease overlaps with some of the very risk factors that we are concerned about in cardiology. So how prevalent is sleep-disordered breathing in cardiovascular patients? Well, by far and away, drug-resistant hypertension has been the best studied in patients with obstructive sleep apnea, and more than 80% of the patients who are on 3 or more antihypertensive meds will have sleep-disordered breathing, most likely obstructive sleep apnea. But then if we look at congestive heart failure, where there may be some central and some obstructive apnea, approximately 50% of the patients with congestive heart failure will have sleep-disordered breathing, and about a third of the patients with coronary artery disease will also have sleep-disordered breathing. So this is a relatively common disease state that we see in our cardiovascular practices. So how does sleep apnea get to cardiovascular disease? And I'm going to drill down on this a little bit more later on in the talk. But in general, we worry about the physiologic effects of hypoxia and increased sympathetic activity, as well as inflammation and oxidative stress coming together to lead to cardiovascular disease. And the mechanism is through hypertension, through direct myocardial injury, through cardiac ischemia, both directly as well as for the development of atherosclerosis, so somewhat indirectly, for the development of arrhythmias, both atrial and ventricular, and through the mechanism of stroke, through cerebrovascular disease, but also probably through hypercoagulable states, plaque rupture, et cetera. So we know that the cardiovascular response to normal sleep is to actually relax the body, decrease heart rate, and decrease sympathetic activity. But in sleep-disordered breathing, in particular sleep apnea, these things are actually counter-regulatory, and sympathetic activity increases, as does blood pressure, et cetera. Now, what specifically about obstructive sleep apnea? Well, we know that the negative intrathoracic pressure itself causes significant increase in transmural pressure and increase in left ventricular afterload. And this leads to LV remodeling with hypertrophy as well as additional strain on the ventricle and fibrosis. It also leads to increased venous return, which leads to right ventricular overload and impaired left ventricular filling. So the mechanical effects of obstructive sleep apnea are thought to be important. Now, the sympathetic activity is also something that we think is very important. And this increase in sympathetic tone can lead to arrhythmias, increased afterload, and increased systemic vascular resistance, can be driving hypertension, et cetera. And then finally, hypoxemia, leading to oxidative stress and platelet activation. And you can imagine worsening atherosclerosis, plaque rupture, clots, and myocardial infarction, as well as another driver for left ventricular hypertrophy. And finally, significant afterload increase on the right ventricle due to pulmonary vasoconstriction in hypoxemic states. And so you can imagine that these three pillars, the negative pressure, sympathetic activity, and hypoxemia, can connect directly to heart failure, either indirectly through ischemic heart disease or directly through negative remodeling of the ventricle. Now, what about central sleep apnea? Well, again, although we don't have the negative intrathoracic pressure that we see with obstructive apnea, because in this case, there's a loss of drive to breathe, we still see the same apnea-induced and hypoxia-induced reoxygenation cycle leading to endothelial dysfunction and inflammation, left ventricular hypertrophy, and again, increased risk of thrombosis, this leading to both stroke as well as myocardial infarction. And then on the other side, we also see adrenergic stimulation, again, norepinephrine release, leading to the same cascade of events that we saw with the obstructive sleep apnea patients. So both obstructive and central apnea, through the pathways of hypoxia and adrenergic stimulation, are thought to drive the development and potential worsening of cardiovascular disease. Now, if we think specifically about central sleep apnea and connect it to heart failure, this is a diagram that I borrowed from Bill Abraham. He actually borrowed it originally from me and made it look nicer. But we have a cycle of central sleep apnea, increased sympathetic drive, apnea, hypopnea, hypoxia and arousals, ischemia and inflammation cycling through. But you can see that this one cog would actually fit very nicely with heart failure, where the activation of the sympathetic nervous system and hypoxia would then increase heart pump stress, impair heart function further. And you can see that these two disease states would actually help to drive each other. The worsening of the heart failure, likely the worsening of the central apnea, but the worsening of the central apnea driving worsening heart failure over time. So we know that many of the risk factors for sleep apnea, unfortunately, are also the risk factors for cardiovascular disease. So obesity being a risk factor for cardiovascular disease is associated with diabetes, hypertension, inflammation, and vascular disease. And there's a whole branch now of medicine looking at the inflammatory state of obesity and insulin resistance. We also know that strokes are associated with atherosclerosis, atrial fibrillation, et cetera. And then heart failure, again, associated with atherosclerosis and inflammatory state and increased adrenergic tone. And so one of the challenges that we've had in making associations between sleep apnea and cardiovascular disease is that there are many covariates that are collinear, meaning that the same risk factors for sleep apnea are some of the same risk factors for cardiovascular disease. And teasing out the association has been challenging. And some of the studies like the Sleep Heart Health study, et cetera, showed modest associations of sleep apnea with cardiovascular disease. But the reality is that there's probably a magnification of the risk factors when you have both sleep apnea as well as some of the other risk factors with cardiovascular disease, and likely vice versa. So how do we get from obstructive sleep apnea to heart failure? Well, again, kind of reiterating some of the things from earlier in the talk, the activation of the sympathetic nervous system, hypoxia, and vasoconstriction, each leading to several of the risk factors: atrial fibrillation, ventricular tachycardia, pulmonary hypertension, all driving heart failure. And then on the other side, hypertension and coronary artery disease having direct negative effects on the left ventricle. And if we think about as patients lie back and their volume overloaded, they develop more rostral fluid reaccumulation, and that increases their neck circumference. And we have data here from Penn and from other centers around the world that if you MRI these patients, that you actually see that some of this edema further narrows the airway, and therefore the volume overload of heart failure actually makes the obstructive sleep apnea somewhat worse. And this is why we may see some night-to-night variability based on the volume status of our heart failure patients. And the same is true for the sympathetic nervous system activation. Over the last 10 years since this slide has been made, there's even more associations in terms of fibrosis and microvascular changes and inflammation that we've seen with sympathetic activation. But if you think of the traditional things, the impact on the kidney, on the blood vessels, the lungs, and the peripheral musculature, activation of the sympathetic nervous system is really one of the negative actors in terms of promoting and progressing heart failure over time. Here's some data from Viren Summers from the Mayo Clinic, just looking at what happens in patients who have sleep disordered breathing and when they're treated with CPAP. And this is actually a measurement of how much a sympathetic burst that they have. And so normal subjects have this much, obese subjects without sleep apnea, but those that have sleep apnea actually have a higher level of sympathetic tone. And those patients that were treated over time have a significant reduction in their sympathetic tone. So just treating the sleep disordered breathing and keeping everything else the same, there is a significant reduction in sympathetic activity. Now we know that obstructive sleep apnea is associated with the risk of developing heart failure. And again, I had mentioned before the Sleep Heart Health study that was published back in 2001. And this study reported that the presence of obstructive sleep apnea alone increased the risk of heart failure more than twofold, even independent of other risk factors, even controlling for obesity and hypertension and some of the other risk factors that we know are associated with heart failure. So we know that OSA is clearly a risk factor for heart failure. We also know that as apnea-hypopnea index increases in sleep disordered breathing, mortality also goes up significantly. This is work from Dr. Punjabi at the time at Johns Hopkins and showed that as the apnea-hypopnea index increased, mortality went up significantly. And what's the mechanism of mortality in these patients? By far and away, it's cardiovascular disease or cerebrovascular disease, sudden cardiac deaths from arrhythmia, myocardial infarctions, and strokes. And again, there's almost a dose-response relationship between apnea-hypopnea index and mortality. The same is seen in central sleep apnea, and no matter where you cut off the apnea-hypopnea index, those that have central sleep apnea are much more likely to die than those patients that don't. And this is in a cohort of heart failure patients published by Dr. Javahiri back in 2007. And then we know with severe central sleep apnea that patients that are untreated have a significantly high mortality, 40% at 5 years, 60% at 7 years. And again, by far and away, the vast majority of these patients are dying from end-stage heart failure, myocardial infarctions, sudden cardiac death, and stroke. So the same cohort of cardiovascular disease that's causing the same degree of difficulty. Now, what about driving other cardiovascular outcomes? Well, certainly in my world, in the heart failure world, one of the things that we've been very much focused on is heart failure readmissions. And we started to notice a pattern that those patients that had untreated sleep apnea, in this case, it's central sleep apnea, were much more likely to be readmitted to the hospital than those patients that did not. And so the question is the sleep disordered breathing driving worsening heart failure? Is it making patients more fatigued and therefore it's more difficult for them to follow their medical regimen, more difficult for them to do the lifestyle changes? Are they forgetting their medications? Are they fatigued? Are they depressed, et cetera? Or is it a physiologic effect? Are these increased in sympathetic adrenergic tone leading to more atrial fibrillation and decompensation, or ventricular tachycardia, or worsening hypertension that's not as well treated with the medication? So the mechanism here is not clear, but the outcome is clear, that those patients that have sleep disordered breathing, in this case, central sleep apnea, are more likely to be readmitted to the hospital. Now, what happens to patients with obstructive sleep apnea if we treat them and they have a dilated cardiomyopathy? And so here's a cohort of patients. This was published a very long time ago in 1991, a very small number of patients. But we see that in patients with obstructive sleep apnea at baseline, and then they're treated with nasal CPAP, these patients had an improvement in their ejection fraction. It's similar to the improvement that we see when we start someone on a beta blocker. When we give them adrenergic blockade, we see an increase in ejection fraction somewhere around 5%, sometimes up to 10%. But interestingly, if the CPAP was withdrawn, these patients had, again, a decrement in their ejection fraction. And the same was true in their functional capacity. Patients improved on average, or in this study, one entire functional class, which translates into actually an improved prognosis as well as an improved quality of life when they were treated with CPAP and their functional capacity returned to baseline when the CPAP was withdrawn. So studies like this were very intriguing to say to heart failure doctors, is sleep apnea actually a therapeutic target? Is it just like adding another medication to the regimen, adding another neurohormonal blockade to already the 5 medicines that we have most of our patients with heart failure with reduced ejection fraction taking based on our current guidelines? Here's another slightly larger study that was published in the New England Journal in 2003, just showing patients having an improvement in ejection fraction when their obstructive sleep apnea was treated with positive pressure. And so this study got a lot more attention because it did have a control group and they followed over time, and this was statistically significant, suggesting again that treatment of the obstructive sleep apnea actually improves the outcome of heart failure patients. So our center decided to take a look at this in some detail, and we decided to start screening our patients who were admitted to the hospital with decompensated heart failure. We did a sleep study about 24 or 48 hours right before they were going to be discharged from the hospital. So in theory, they were converting over to oral meds and their volume overload had been addressed and their meds had been titrated. And we decided to look at those patients who tested positive for sleep apnea, and then we discharged them with a auto-titrating CPAP device and looked at what happened in 30-day readmissions. And what we found was that patients who actually used the auto-titrating CPAP device, not a single patient was readmitted over the 30 days that we were looking at. But those patients that either chose not to use the device or only used it intermittently actually had a readmission rate that approached about 25% at 30 days. And this is actually the Medicare kind of national readmission rate. So treating the obstructive sleep apnea in this case was important. Now, we also know that those patients that were using the CPAP regularly, maybe they were more likely to take their medications or have other behaviors that would have promoted better health. But this was very intriguing and convincing enough to our administrators to allow us to continue this program, where to this day, we continue doing inpatient sleep studies in patients who have not had them as an outpatient. And we do send those patients that test positive for sleep apnea home with an auto-titrating CPAP device, in the hopes of not only improving their quality of life, but also preventing readmissions and improving their quantity of life. So what do these patients look like that have sleep disordered breathing and chronic stable heart failure? Well, if we compare a large cohort of patients, almost 7,000 patients, we see that the BMI is slightly larger in the patients with sleep disordered breathing. They're slightly more likely to be male. Their ejection fractions are slightly lower, and they're slightly sicker with their heart failure. They're much more likely to have atrial fibrillation, which is no surprise to those of us that take care of these patients, that AFib is very common in patients who also have obstructive sleep apnea and vice versa. And patients that are waking up with nocturnal dyspnea or reporting nocturia, which I'm going to come back to. But nocturia is actually a very common complaint in our clinic. And we've made an association, as many other centers, that frequent nocturia is actually a marker of sleep disordered breathing, in addition to fluid redistribution when patients are lying back. So who do I need to screen? What is kind of the state of the art? When should patients be screened? And we know that the prevalence rate is about 50 to 75%. And it has been documented in patients with heart failure with reduced ejection fraction, so low ejection fraction or systolic heart failure, as well as with heart failure with preserved ejection fraction. Those that have normal ejection fractions, either greater than 40 or greater than 50%, there's really no difference in the prevalence between these groups. And in patients with acute decompensated heart failure, the prevalence can be even higher. And we certainly saw that when we were enrolling in our clinical trials and we presented this to our nursing grand rounds. We had many of our nurses calling us because they were noticing either Cheyne-Stokes respiration or sleep apnea on the respiratory monitors in our ICUs. But oftentimes, as the patients became more compensated, some of those patients actually improved. And so we know that decompensation tends to exacerbate the sleep disordered breathing. So who do I need to screen? In our center, we do a standard heart failure program screening for all new patients, and we ask them 4 questions. We ask them, 1, do you snore? 2, were there witness apneas? We try to get a family member or someone else who has seen the patient sleep, whether or not there's witness apneas, whether they have daytime napping or fatigue, or if they have fallen asleep during routine activities. And then in the last 2 years, we've added a question around nocturia. How frequently do you get up at night to urinate? And some of that has to do with when they take their diuretics, et cetera, but we have found a strong association between nocturia and sleep apnea. And then from the medical history, do they have hypotension, a history of atrial fibrillation, or frequent ICD shocks? And patients who have witness apneas automatically get screened through our sleep center, or if they have 2 or more of these risk factors, then those also trigger screening for us, because we know that the pretest probability in this population is very high. When do we screen? We always screen at the initial visit to the heart failure program. We always do a comprehensive history and physical. We give them quality of life and heart failure specific questionnaires, and typically do a 6-minute walk test. As part of all of that screening, we also do a sleep screening. And if there's controversy, we may also do some specific sleep questionnaires. We also, during the heart failure admission, as I mentioned earlier, screen all of our patients on the heart failure service. And if they haven't had a sleep study, we try to get it done inpatient 1 to 2 days before discharge. We do them 6 nights a week, every night except Saturday night. They can be done by our respiratory staff. And if positive, they are sent home with an auto-titrating CPAP and follow-up in our sleep program. What are the lessons that we've learned around screening? Well, one is make it simple. We have a one-click order in our electronic health record that automatically refers the patient for sleep testing. It includes the appropriate conditional orders for either in-home or versus in-lab testing, and also sends the sleep lab important demographic information, insurance, diagnoses, and risk factors that are pulled from the chart into a report automatically in the order. We also try to make it important, is that we always say that the physician or the APP discusses the risks of sleep apnea and the potential benefits of treatment. We make the argument that this is yet another non-drug treatment, but may improve their ejection fraction, which our patients are oftentimes focused on, and improve their quality of life. And we tell them that it's another opportunity to kind of circle around them with all of the things, in addition to medications, lifestyle changes, and interventions on their other comorbidities. Treating their sleep is also one of those pillars that we want to address. And then lastly, reminders. We assess CPAP compliance in the heart failure clinic as if it were any of the other medications. So when we do medication reconciliation, we also ask about CPAP. If they're having difficulty with the device or a technical thing, then we have a mechanism to refer them over to one of the nurse practitioners in the sleep program who can then troubleshoot that. And we had a problem for many years that we were referring many patients for sleep testing and then finding out months later that they never actually followed through on it. And so now we do have an alert that lets us know if the patient was referred and then that referral never got completed, that we can readdress that with the patient at future visits. So in conclusion, sleep apnea is very common in patients with cardiovascular disease. It is underdiagnosed and undertreated. And a structured screening program is really critical, we think so, within the cardiovascular sections. And that's because we have the patients. We're seeing them first, and we're seeing them very frequently. And that enables us to be able to refer them. Sleep apnea leads to decreased quality of life and likely increased mortality. Sleep apnea is associated with increased adrenergic tone and inflammatory markers due to hypoxia. And we think that this is likely the pathophysiologic mechanism that links sleep apnea with cardiovascular disease and ultimately cardiovascular events, including stroke. And sleep apnea diagnosis and treatment really requires a team approach between both the cardiovascular specialist, the primary care team, and the sleep team. And we're fortunate in our center in that we have a niche program within our sleep center that really does collaborate with us and works with us in terms of getting our patients screened in an effective way. So thank you very much for your attention, and I'll be happy to take questions during the question period. Thank you so much.
Thank you, Dr. Goldberg, for an excellent presentation. Before our next presentation, we have a word from sponsor Itamar Medical. WatchPat 1 is a fully disposable, single-use home sleep apnea test with the same level of accuracy and reliability of all WatchPat products. It provides a comprehensive auto-scored report immediately after the study is completed with AHI, central AHI, RDI, and ODI based upon true sleep time and sleep staging. It utilizes a simple smartphone app to transmit the study data. As soon as the study is completed, results will be ready to review by the clinician. Thanks to WatchPat 1's single-use design, it helps to increase infection control for both clinics and patients. If you have an interest in learning more about the WatchPat products, please contact Itamar at info@itamar-medical.com or visit itamar-medical.com. And Lisa, could you do me a favor and show your PowerPoint, make yourself the presenter, because it looks like we have a blank screen for a minute, and I'd like to be able to show the WatchPat 1. Excellent, thank you. So if you have an interest in learning more about WatchPat products, please contact Itamar at info@itamar-medical.com or visit itamar-medical.com. And Lisa, if you can move to the introduction slide for Alan Schwartz. I am happy to introduce Alan Schwartz, MD, as Professor of Medicine at Johns Hopkins University for over 30 years. Dr. Schwartz played a pivotal role in building the Johns Hopkins Sleep Disorder Center. He launched and directed the Sleep Medicine Fellowship Training Program and the Center for Interdisciplinary Sleep Research and Education. Dr. Schwartz graduated from the Johns Hopkins School of Medicine, completed his residency in internal medicine at Mount Sinai Medical Center, and fellowship in pulmonary critical care and sleep medicine medicine at the Johns Hopkins School of Medicine. He is currently an adjunct professor at the University of Pennsylvania Perelman School of Medicine. Welcome, Dr. Schwartz.
Thank you so much, and thank you to the conference organizers as well. We'll be talking for the next few minutes about the role of home sleep testing in diagnosing and treating sleep apnea. We've already gotten from Dr. Goldberg a little bit of a window on what this home portable testing really entails, since it's also been deployed in the latter part of his talk in the hospitalized patient with cardiovascular disease and heart failure. By way of disclosures, you have these various disclosures, including Itamar and Respicardia, where I've been doing some work with both of these companies for some time. What I'd like to do is really review the home testing landscape here, start with ASM, American Academy of Sleep Medicine Clinical Practice Guideline updates on home testing platforms. And after a comprehensive literature review, they deem that polysomnography or home sleep apnea testing is a legitimate way to diagnose uncomplicated adults with signs and symptoms indicating a risk of moderate to severe sleep apnea. And I would say that most all of the cardiovascular populations that we've heard discussed already really have moderate to severe obstructive sleep apnea or central sleep apnea or combinations of both. So this is really a prime target population. The ASM deemed as technically adequate two styles of home tests, one that is really primarily respiratory based with nasal pressure, respiratory effort, and SpO2, and the other which is really based on PAT technology, peripheral arterial tonometry, which is complemented by SpO2 and actigraphy to generate a hypnogram as well as disorder breathing indices. And so we'll really take a high-level view at both of these, except to say that there are a number of reasons why you might want to consider, or a number of variables you might want to consider as you make the decision as to what constitutes a viable home sleep apnea testing platform. We'll focus primarily on the accuracy that is generated by these home testing devices, both in terms of its ability to assess the presence, severity, and type of sleep apnea. But you in your own centers might consider the simplicity in deploying these units in the field, the failure rates, which should be acceptably low, the ease of downloading and scoring the recordings from these devices, and obviously in the COVID era, the risk of transmitting contagion and sterilization and whatnot, so that the devices, if they are reusable, can be reused. I'd like to start though with the gold standard, which is considered to be the in-lab sleep recording, shown here in a compressed all-night view in the top portion of the panel and an exploded several-minute view in the bottom portion. And it's no secret to anyone that if you look at the airflow trace, you can see typical apneic episodes lasting approximately 30 seconds apiece. They're associated with respiratory efforts in this case, indicating obstructive episodes. They terminate with arousals and oxygen desaturations from sleep. And as you look at this, you can spot this disorder really from a mile away. It doesn't take any sophisticated instrumentation to do so, but there are much more subtle and mild degrees of sleep apnea that we want to be attuned to so that we don't miss the disorder, particularly in the non-sleep patients, such as those with cardiovascular disease. And so as we try to drill down and look at home sleep testing platforms, it's a little bit like this guy here, who is, rather than looking at the whole elephant from the curbside here, is really looking at just a portion of the elephant, in this case, 1 or 2 or 3 or 4 signals, and concluding or drawing a conclusion that indeed it is a mammoth after all. But you will see over the course of the next few minutes that these home testing platforms are rather robust. And when you combine it with your understanding of clinical and physiologic indicators of sleep apnea, you can get quite a lot. And that has led to the genesis of the so-called Type 3 study, which is a 4-channel cardiorespiratory recording in the home or portable monitoring setting, consisting of some measure of airflow, effort, oximetry, and perhaps one other parameter, such as body position, etc. This is a Type 4 study, which effectively involves even one less channel, usually 3 or less cardiorespiratory channels, in this case, oximetry and airflow, maybe in a respiratory effort, maybe not. But these type 4 and type 3 studies all really basically tee off a native read of tidal airflow. And that really leads to the genesis of really two types of home testing platforms. Those that are flow-based, based on tidal airflow assessment, so that apneas and hypopneas can be recognized based on alterations in flow, amplitude, and shape primarily, or they are sleep and arousal-based. Sleep and arousal-based programs detect the footprints of these sleep disorder breathing episodes. Both flow and sleep and arousal-based systems share in common the use of oximetry to detect significant drops in saturation when patients have these episodes. But in contrast to the flow-based recording systems, the arousal-based recording system, of which the WatchPat is probably the leader, if not the only one in this domain, looks at signs of arousal that terminate the apneas themselves, and in conjunction with the oximetry dips, concludes that sleep disorder breathing episodes have occurred. Suffice it to say that there are a lot of different systems that are out there utilizing a variety of different physiologic parameters: airflow, tidal volume, respiratory effort, oxygenation, some with CO2. Sleep-wake state is assessed in various ways, and cardiovascular outcomes as well. And it's because of these different physiologic signals that new criteria called the Scoper criteria have been defined to describe the type of recording platform that you might be interested in using. Suffice it to say that I think the most prominent and most reliable platforms for home-based testing are really the flow-based and the arousal or sleep-wake-based devices. And some of these devices are noted in these two boxes here. When you look at a flow-based system, recognize that we're looking primarily at the flow amplitude and the shape, and we'll get into a little bit more detail, to discern whether or not an apnea or hypopnea has evolved. And then we're looking for some confirmation in these devices, usually in the way of a significant desaturation at either the 4 or the 3% threshold level. But be aware of the fact that these systems do not assess arousals from these events, and so some hypopneas or respiratory-related arousals will not be detected as a result of the lack of arousal detection. And these systems in general do not measure total sleep time. And it's on that basis that they report a respiratory event index. It consists of the total numbers of apneas and hypopneas divided by the recording time rather than divided by the total sleep time. And as a result, if patients spend a substantial portion of the night awake, the recording time will be much larger than the total sleep time, leading to an underestimation of the presence and severity of sleep apnea. And that's essentially shown in this study here, which describes in a clinic-based sleep center population the prevalence of sleep apnea at various degrees of apnea-hypopnea index thresholds for diagnosing no, mild, moderate, or severe disease. And it's really based on these that we find that in-lab polysomnography, the dark bars, lead to, in general, a right tip to these prevalence rates, with more patients diagnosed with moderate to severe sleep apnea in the case of in-lab polysomnography, and more patients that either slip detection or only diagnosed with mild sleep apnea when they're using flow-based home sleep apnea test devices. And it's really on that basis that we have to distinguish between the true measure of AHI and the respiratory event index, being total numbers of events divided by, in the case of in-lab and sleep-based recording systems, total numbers of events divided by total sleep time, rather than dividing these total events by the total recording time. To add one other issue to the table here, the events, the inaccuracies that result from some of the flow-based systems are really based on the fact that hypopnea definitions have evolved and flip-flopped back and forth over time. And as you can see in this table, we have various standards that have been promulgated since the late 60s through the present time based on flow recordings, where a hypopnea is defined now alternatively by either a 30% or a 50% reduction in tidal airflow that is accompanied by either a 3% or a 4% fall in oxygen saturation, with the added complexity that respiratory-related arousals, which are oftentimes included in the hypopnea index, are diagnosed based on EEG arousal criteria being met. Now, needless to say, with home-based recordings, if you can't assess for arousal, your hypopnea index will vary depending on the thresholds that you use for reduction in flow and for changes in oxygen saturation. And the changing criteria that have been applied to defining hypopneas over time have reminded me of the expression that is attributed to Ben Franklin, who says that when you are finished changing, you are finished. And that was several hundred years ago that was said, but in fact, we're really still having problems and troubles deciding how to score these hypopneic episodes. And so what I'd like to do is really suggest that there are complementary sources of information that when hypopnea based on flow-based recordings shows you a modest reduction in flow with inspiratory flow limitation or partial upper airway obstruction during sleep, we might not discern a significant desaturation. We might not have an arousal available to us because of the lack of EEG, but we may have other physiologic indicators that give us the footprint or the fingerprints of an arousal or activation of sympathetic nervous system activity that may tell us that, in fact, ventilation was compromised to the point that sleep has been disrupted in a significant way. And it's really on that basis that I would suggest that this signal coming from peripheral arterial tonometry provides a relative index of vascular tone. It is a plethysmograph that wraps around the finger and responds to pulsatile blood flow with each heartbeat. And it's based on the volume of pulsatile flow into the finger that you can detect an either greater or lesser degree of digital artery vasoconstriction. It provides this relative index of vascular tone. And when you've aroused from an apneic episode, indeed what you see is that there's a vasoconstriction that occurs in the finger, and it is marked by a drop in the pulse volume amplitude here. You can also see, as patients transition from different stages of sleep and wakefulness, you will see that REM sleep and wakefulness are generally characterized by a reduction in PAT amplitude, indicating increases in sympathetic tone. And it's really on that basis that the WatchPat device automatically generates a hypnogram and complements the assessment with hypnogram, complements it with other physiologic signals such as heart rate, oximetry, snoring, and body position, so that they have automatically generated the sleep structure, including non-REM and REM periods that you see here, as well as estimates of sleep disordered breathing episodes. And it's on that basis that from this recording alone, without even diving into the recording, the report itself allows you to discern that this is a patient who has frequent intermittent desaturations, characteristic of a patient with sleep apnea, that the REM periods are usually associated with more profound desaturations, and there's tremendous heart rate variability that is due to the sympathetic activation of the sympathetic nervous system or adrenergic surges that terminate these apneic episodes. We see snoring, and we see that the apnea is present in any body position in the top pane here. And you can really discern at a high level from 20,000 feet, you can discriminate the effects of sleep stage and body position. In this case, in the left panel, you can see that the REM episodes are associated with marked oxygen desaturations, and that they're associated with increases in heart rate variability. It's characteristic of sleep apnea that predominates during REM rather than non-REM sleep. You can also discriminate positional sleep apnea on most of these devices that have a body position sensor, where you can see that the oxygen desats and the heart rate variability that we saw on the last slide are really pronounced when the patient flops over to his back, but not when he's on his side. The snoring goes up here when he's on his back, also indicating that in all likelihood, he's having hypopneas rather than complete airway occlusion or apneic episodes. So you can tell a lot from these types of reports, right from the 20,000 foot level, before you sort of zero in and look in detail at the recording itself. You can get a lot of discriminative information. And we can also assess the status of upper airway patency based on simply the production of noise, where when people go off to sleep, their upper airway obstructs. The obstruction is mitigated by neuromuscular activity that can restore airway patency. And it's really on this basis that we have a whole spectrum of upper airway patency that is really reflected by the magnitude of the snoring in these events, the reductions in flow amplitude, and or the severity of the oxygen desaturations. Now, looking at the PAT or watch PAT-based, non-flow-based home sleep testing technologies, you will find that, as we've seen in the last reports, they have highlighted the fact that we can pick up total sleep time as well as non-REM and REM time, thereby making our assessment of apnea-hypopnea index equal to the numbers of events divided by total sleep rather than total recording time. But in addition to that, we see that we're also able to pick up the signs of arousal that terminates these apneic and hypopneic episodes. And that's shown by the intense sympathetic surge or adrenergic surge that terminates these episodes. That's represented by digital vasoconstriction here at the end of each episode, coinciding with desaturations. And when adrenergic surges occur, the heart rate goes up markedly. And so this pattern of vasoconstriction in the PAT signal with increases in heart rate, I will call the reciprocal pattern, and it indicates that an arousal has occurred. We make it specific to sleep disorder breathing episodes by detecting either a change in snoring amplitude or a change in the oximetry, a dip in the oximetry signal. Now we can see that that pattern in greater detail if we blow up on these recordings, where we see here 3 such reciprocal patterns, adrenergic surges, but we can easily discriminate the hypopnea that is characterized by augmenting snoring from the apneic episode in which there's silence, respiratory silence here and here. And as a result, we can easily state, even without flow, that we see hypopnea in one case and apnea is occurring in the other case. And these are important because they steer us to different therapeutic alternatives. Based on the severity of airflow obstruction, upper airway obstruction, hypopnea is only due to partial rather than complete upper airway obstruction. And as a result, it's a whole lot easier to open a partially than a completely obstructed airway based on simply quantitative differences in the collapsibility of the airway, a parameter which we would call physiologically P crit, or critical closing pressure for the airway. And it's these patients who have obstructive hypopneas rather than apneas that really tell us something about whether they will respond, more likely respond to a modest degree of weight loss, a little bit of mandibular advancement with an oral device, or low levels of CPAP on an automatically adjusting CPAP device where you don't have to set the top end of the range up at 20 centimeters of water, but rather can set it at 10 or 12 and still cover the spectrum of upper airway obstruction in those that manifest predominantly as hypopneas rather than apneas. But it's not only the obstructive side of the coin that we can sort of discern, but we can also look at whether the apneas are predominantly central or obstructive from nearly every one of these home sleep apnea testing platforms. Now, I would point out that someone like this who has severe sleep apnea, it's no mystery that he has 80, 90, or 100 episodes an hour. It's really more a question of what type of apnea it is. And the fact is, you can observe the fact that he has intermittent hypoxia, desaturations, that accompany these REM episodes. One of the features of central sleep apnea and chain stroke breathing in the cardiovascular patient is the fact that chain stroke breathing tends to get better, not worse, during REM sleep. And in this case, we see just the opposite, that this is an individual whose REM events are more severe, leading to greater desaturations, strongly suggesting that this is severe obstructive and not central sleep apnea. And you can see that as you drill down, even from the report, where the periodicity in the report of the patient with chain stroke breathing is absolutely regular. The periodicity here is rather jagged in terms of the severity of the desaturations, which are not reproducible one after the other, but rather irregular, again going for more of the obstructive rather than chain stroke breathing pattern. And so you can look at a high level of the report to discriminate obstructive from central episodes based on the symmetry of the desaturations, the periodicity, and the fact that central sleep apnea and chain stroke breathing tend to be much less in REM than in non-REM sleep. We can also drill down into the recording itself, and whether or not you have an airflow signal present, you can clearly discriminate respiratory efforts during the events, and even on the wrist actigraphy, we see respiratory efforts, and we see those efforts reflected in the PAT signal itself in the finger, just based on the fact that we see respiratory fluctuations, small fluctuations in the amount of blood flow as a function of the respiratory cycle when patients are breathing in hard against an occluded upper airway. In contrast, what we see in the patient with a central sleep apnea is we see marked regularities in the degree of desaturation with each event. We see the absence of respiratory effort. We see the sinusoidal patterns that occur in oximetry and airflow, and even the PAT signals themselves. And these are clearly central, not obstructive events. We can also discriminate in the cardiovascular patient a unique parameter that is characteristic of patients with heart failure and chain stroke breathing, and that is namely the circulation time. Literally the time it takes for blood to get from the lungs with the resumption of breathing out to the finger, through the left heart and out to the finger. The circulation time is, in this patient, is 30 rather than a normal circulation time of 15 seconds, double normal. Again, cementing our notion that this is clearly chain stroke and central sleep apnea, not obstructive apnea in nature. No respiratory movement, we've commented on that, and you can see at both levels of both the report as well as digging into the recording itself that you've got abundant features with or without the presence of an airflow signal to discriminate the central from the obstructive apnea patient. And it's really on that basis that I would really suggest the following workflow for your home sleep test recordings or recordings in the hospital ward on your heart failure services. One is take a look at the scoring at a very high level, 20,000 feet. Begin to discriminate the patterns that may cluster during REM versus non-REM sleep, or may cluster in one body position versus another. And you can check the hypnogram, at least on the WatchPat recording, and verify patterns that allow you to verify the non-REM, REM, and total sleep time. In terms of the assessment of sleep apnea severity, I would really rely initially at the high level on the ODI, the oxygen desaturation index, because if it's over 20, you know you're dealing with a level of moderate to severe sleep apnea, and it's really only going to be a question of whether it's obstructive or central. And as mentioned, you can drill down at both the report and the recording level to determine whether you're dealing with predominantly central versus obstructive etiology. And it's really on that basis, a combination of computerized and automated scoring, examining the features at both the report and the recording level, that allows you to generate a final report to characterize patients for the presence, severity, and type of sleep apnea with much greater confidence from all of these home testing devices. I'll stop there and for a pause and let you introduce the next talk.
Excellent. Thank you so much for that presentation. Audience, we do have one other presentation, which will be about treatment. And I do apologize that we are going over the time. I hope you'll be able to continue to stay on. Let me do a quick word from sponsor Respicardia, and then we'll get right on to the presentation on treatments. Do you see patients who continue to struggle with central sleep apnea? Some central sleep apnea patients do not adequately respond to their current sleep therapy, are not consistently compliant with mask-based therapy, or are not candidates for certain types of mask-based therapy due to heart failure with a reduced left ventricular ejection fraction. The Remedy system is a proven implantable sleep therapy specifically designed for treating central sleep apnea. It is unique in that it removes patient compliance concerns and uses the body's own breathing systems to restore a natural breathing pattern. The Remedy has demonstrated consistent and sustained long-term safety and effectiveness benefits that has been shown to reduce the severity of CSA, improve sleep, breathing, and quality of life. The Remedy is FDA approved for moderate to severe central sleep apnea in adults. As a surgically implanted device, there are possible risks, which may include pain, swelling, infection, and others. Remedy can be used as a first-line treatment option for patients, but it may be an especially welcome option for patients who continue to struggle with central sleep apnea. If you see patients who may benefit from Remedy, please contact Respicardia at info@respicardia.com or visit www.respicardia.com to learn more. Now I'm happy to hand it back to Dr. Schwartz for his presentation on therapies. Please do continue to input your questions as we will try to get to a few of those at the end. Dr. Schwartz, since we are running over, if it's possible at all to condense this presentation, and the audience might appreciate it. Thank you so much.
Great, I really appreciate it. And again, really exciting to tell you about some new therapeutic advances for what is really a very difficult disorder to treat based on existing technologies to this point in time. Indications and contraindications, warnings, et cetera, are shown here. Same disclosures as a moment ago. Suffice it to say that we'll focus on central sleep apnea, since the approach to obstructive sleep apnea has been for many, many years. CPAP is the primary treatment for moderate to severe sleep apnea, captured by this cartoon, which really shows that Doreen breezes through chapter 9 of her veterinary textbook of medicine, with every diagnosis being prescribed the same treatment, namely to shoot the horse. But we'll talk about central sleep apnea and chain stroke respiration, briefly touch on clinical presentation pathogenesis, talk about the therapeutic approaches, and then finally highlight what is really a novel approach to therapy that has really provided tremendous hope for an otherwise intractable problem. I'd like to start with a case, a 78-year-old with chain stroke breathing and central sleep apnea. And he had this disorder despite the fact that he reported longstanding snoring, insomnia, and daytime somnolence, with a sleep study showing severe apnea and an apnea-hypopnea index of 53 an hour. He had an extensive history of atrial fibrillation, no heart failure, and this was his sleep recording, which is really very much like what we've already seen earlier in the hour with waxing and waning pattern of ventilation showing tidal airflow, pauses in tidal airflow, apneic episodes with a crescendo decrescendo pattern in both airflow, thorax, and abdominal strain gauges. Similarly, the oximetry is undulating, much the same, and as we've already commented, his circulation time, lung to finger circulation time, is more than double the normal, indicating that it takes more time because of his atrial fibrillation for blood to get through his left heart and out to his finger where the sensor exists. You can see the atrial fibrillation in the irregularities here, even in the compressed ECG tracing. And the reason for central sleep apnea in many of these Cheyne-Stokes patients really has to do with feedback circulatory delay. It's highlighted by the prolonged circulation time. And what we find here is the time it takes for blood to get through the left heart, not just out to the finger, but that delta T out to the brainstem leads to a miscoordination between ventilatory drive or output to ventilatory pump muscles and the signals that are really being generated in the lungs as patients start and stop breathing. And it's that delay that puts the brainstem ventilatory control centers well out of sync with the needs to maintain a normal and stable respiratory pattern and stable oxygenation. And we'll summarize here that Cheyne-Stokes and central sleep apnea patients have a variety of abnormalities that can be, in theory, addressed therapeutically. We've spoken about the circulatory delay, which is primarily addressed therapeutically by optimizing the heart failure management or the atrial fibrillation management. And we've heard already that sleep disorder breathing is one of the non-pharmacologic approaches to treating patients with underlying cardiovascular disease. But the assumption here is that cardiovascular pharmacotherapy has been optimized, and in particular in heart failure patients, that patients are optimally diuresed and euvolemic. But there are other reasons that contribute to Cheyne-Stokes and central sleep apnea, consisting of controller gain. This is really the situation in which the ventilatory control centers are super sensitive to any dip in blood oxygenation, and as a result, they overshoot and undershoot on driving ventilation, almost the equivalent of standing in the shower where the water comes out too hot or too cold, and you flip the nozzle, the faucet too much and rebound or overshoot in one direction or the other. We can damp out the overshooting and undershooting to a modest degree by administering supplemental oxygen so they don't desat as much, and we can also give PAP, CPAP in this case, simply to increase the oxygen stores in the lungs, and that damps out the fluctuations in oxygenation that occur during these Cheyne-Stokes breathing patterns. But the effects of these maneuvers are relatively modest and not nearly sufficient to really treat the symptom complex in patients with moderate to severe sleep apnea. Other approaches have been taken to stimulate ventilation with either drugs like acetazolamide or theophylline, both of which lead to a certain increase in sensitivity of the ventilatory control system and prevent you from developing an apneic episode when you're doing this over and undershooting on your ventilation. The problem with these drugs in cardiovascular patients primarily has to do with the fact that there are electrolyte and acid-base balances that can serve as a trigger to arrhythmias. They're pro-arrhythmogenic, and that becomes more problematic. And so the strategy that has been taken is really to ventilate these patients through their Cheyne-Stokes and central apneic episodes with either some form of non-invasive bilevel ventilation, most commonly adaptive servoventilation, or what we will speak about in somewhat more detail, phrenic nerve stimulation with an implantable pacemaker, for the phrenic nerve. And suffice it to say that adaptive servoventilation took the world by storm about 15 years ago. It was fairly effective in treating central sleep apnea and chain-stroke respiration, but a recent study, multi-center study, demonstrated that it was actually led to excess mortality in patients who have chain-stroke breathing and underlying heart failure, specifically those with a reduced ejection fraction. And as a result, the adaptive servoventilation strategy has been taken off the table with a black box warning from the FDA indicating that it's not to be used for people with chain-stroke breathing and a reduced left ventricular ejection fraction below 45%. And it's really on that basis that we turn to our patient who had an incomplete response to bilevel ventilation, continued to be hypersomnolent, had all other parameters optimized, including his AFib with blocking agents. He was euvolemic. He had a large left atrium that was not going to go away. And so we were really essentially relegated to consider this phrenic nerve pacing device, the Remedy system, to treat his central sleep apnea and manage his symptoms as well as his apneic episodes. Now, this is a fascinating system because it is a fully implantable system that is designed to treat moderate to severe central sleep apnea or chain-stroke breathing. It stabilizes the breathing pattern by activating one hemidiaphragm, one side only. It's got smarts that are built into the pacemaker itself that turn it on automatically during sleep, ensuring therapeutic compliance way beyond what we see with voluntary compliance with PAP therapeutic strategies. And the components of this system are implanted by an electrophysiology cardiologist. They consist of a pacemaker generator that's implanted in the usual place below the clavicle and subcutaneous tissues, a stimulation lead that's passed endovascularly into the region of the diaphragm, endovascularly adjacent to a phrenic nerve on either the right or the left side, and a sensing lead that is passed endovascularly into the region of the diaphragm. And this lead is really designed to optimize therapy in very intriguing ways that really make the pacemaker capable of finding out just how much juice is required to be applied to stimulate the phrenic nerve and pace the diaphragm in order to stabilize the breathing patterns. The sensing lead is key to that system. Well, what are the data that suggests the system actually works? It came in the way of a pivotal trial that was a prospective, multi-center, randomized controlled trial of patients with moderate to severe central sleep apnea, very little obstructive apneas, and all the sleep studies were scored by a blinded core sleep laboratory. The treatment design was randomized as mentioned, with 151 patients implanted. Half were randomized to active treatment for 6 months, the other half to deferred treatment for 6 months. And so at the 6-month time point, we were able to examine the effectiveness of the therapy, and then treatment was turned on in the controls. It was maintained in the treated group and extended now for several years, so that we've been able to observe the safety and long-term durability of the responses to this device. The general characteristics of this central apnea chain-stroke breathing pattern are those of patients with this disorder. They tend to be older, a little bit more men, representing the cardiovascular predominance in this population. Many have heart failure and or atrial fibrillation, and many have a concomitant cardiac pacing device. As mentioned, they all have rather severe central sleep apnea with average episodes of apnea-hypopnea index in the 40s per hour. The primary effectiveness was assessed based on a 50% reduction in the AHI on treatment. And what we see is that the treated group had a much greater response rate to the remedy therapy than the control group, with the difference between treatment and controls being highly significant. But not only was the primary endpoint successful, the secondary endpoints also proved to be successful as well. Namely, that the central apneas went down to nil, essentially, in the treated compared to the controls. The apnea-hypopnea index went down considerably, again, more in treated than controls. They aroused less, and the oxygen desaturation index improved quite a bit more in those on active treatment compared to control. Now, if you're breathing better during sleep and you're sleeping better, then you should get increases in REM sleep, which was achieved, and you should, as a result of better quality sleep, be getting improvements in your overall quality of life, represented by two quality of life indicators, one a general indicator up top, and the second the Epworth Sleepiness Scale. Sleepiness went down markedly in the treated compared to the control patients. And this shows really the fact that over a 3-year time period, these patients are treated and durably treated with absolute elimination of central apneas for the entire time period, and the decrease in the apnea-hypopnea index, the total index, and ODI is really commensurate with the effects on central apneas. This is a therapy that is really designed to treat moderate to severe central sleep apnea and chain stroke breathing, particularly in patients who are symptomatic. Shown here are the aggregate results for the study group as a whole, with the treated patients improving markedly in daytime sleepiness on the left, in patient global assessment, much more marked to moderate improvement in their overall well-being compared to the controls. And then all of those who were implanted were asked about their willingness to undergo the implant again, had they had it to do all over again, and the vast majority said yes, they would definitely go through it all over again. Back to our patient, we see that, as mentioned, his device turns off automatically in the morning at 6 or 7 a.m., which is outside of his sleep window. And interestingly enough, as it turns off at the appointed time here, we see that the stable breathing pattern and oxygenation that is related to the stable bursts of phrenic nerve pacing seen in the ECG lead, that breathing pattern immediately goes back to chain stroke breathing. And this is really one of the novel aspects of this particular device. You set it to turn on in a certain sleep window, say 11 p.m. until 7 a.m., and it will turn on as long as a couple of other conditions obtain. Your patient is motionless, inactive, and your patient has assumed a recumbent position. And if your patient is lying back or lying down and is inactive within this therapeutic window, this pacemaker automatically turns on and paces you out of your chain stroke breathing patterns. So as a result, it really leads to much enhanced compliance or adherence to the device, as seen in our case, where he had the device in for a full 2 years, had no significant apneas, apnea-hypopnea index was normal, and he was achieving extremely good adherence to the device based on these automatic features that are built into the pacemaker can. Symptomatically, he was no longer having restless sleep, his daytime somnolence was low, and he no longer napped since starting therapy. Our topic is cardiovascular, and as a result, we did a sub-analysis of the heart failure treated patients in this pivotal study. And we find that they too show much the same types of effects that we see for the group overall. Namely, that their left ventricular ejection fraction increases, and unlike the adaptive servoventilation, which was associated with increased mortality in this heart failure population, what we find is that if anything, the treated group has diminished mortality over the first 6 months of treatment and observation. Again, correlating with what we saw from Dr. Goldberg as a reduction in hospital readmission rates when you detect and treat sleep disorder breathing in these patients. So the hospital readmission rates are down in the middle panel, and the mortality is maybe a tad down or unchanged. I misstated that earlier, with reductions in readmission rates in those treated and no excess mortality in those with heart failure who were treated with this phrenic nerve pacing system. Similar improvements in global quality of life, really leading me to basic conclusions here that Cheyne-Stokes and central sleep apnea are associated with significant morbidity and mortality, and effective treatment has really been largely lacking. In a large randomized controlled trial, the remedy system achieved durable improvements in sleep apnea, sleep architecture improved, and as a result of sleeping better, patients had better quality of life. And initial findings in the heart failure cohort suggest the potential for increases in left ventricular ejection fraction, reductions in heart failure admissions, and hopefully no excess mortality in those treated with this phrenic nerve pacing system. So I'll stop there, hopefully leave you a couple minutes for questions, and really appreciate everybody's attention through the entire presentations.
Thank you so much, Dr. Schwartz. And yes, we still have the vast majority of folks on. So let's do a couple of questions. And just a reminder, a PDF of the slide deck is available in the handout section of your control panel. And this webinar is being recorded. In the follow-up email sent tomorrow, we will include a link to the recording. And be sure to take the course evaluation, which will appear on your screen after the webinar ends. First question, how aware are cardiologists in general about the relationship between sleep disordered breathing and cardiovascular disorders? My experience is that many are not.
So this is Lee Goldberg. To answer that question, I think it's getting a lot better. I think that you'll see that in the heart failure guidelines, sleep apnea is listed as one of the important comorbidities and a potential therapeutic target. And I think that there's been a lot of education around, especially obstructive apnea, and cardiovascular disease. Certainly our electrophysiology colleagues recognize the association between AFib and obstructive sleep apnea. And our program actually screens patients before they get AFib ablations, because the EP docs know that if they treat the obstructive apnea, the percentage of patients that have successful ablations at 6 months and 1 year for their statistics actually looks a lot better. So they're very motivated. I do think that sometime in the general community and general cardiology, if these cardiologists are not engaged in some of these other programs, that they don't understand the relationship. And I think a lot of what we have to do is do more webinars like this to kind of get the word out that it's an important thing to screen for and that there are effective treatments.
And I think the other thing that's really neat is that now that screening platforms have become a lot more user-friendly, they're easy to deploy in the field at point of care, whether it be outpatient cardiology clinics or inpatient cardiology wards. And that really allows us to sort of build interdisciplinary programs that, like the ones you've highlighted at Penn, that really make it just a lot more fun. It's an interdisciplinary team, and we're all sort of trading insights and impressions based on our different points of view and perspectives.
How reliable is home sleep testing?
I think it's not so much the home testing platform, it's the eyes and the brain power that goes into looking at the results. And as I mentioned, I think you can wring a lot of information out of almost all the home testing platforms. But you can certainly figure out at a high level from the report what areas you've got questions on and where you need to dive into the recording to get greater clarification about the sleep disorder breathing patterns, namely the presence, severity, and the type of sleep apnea. And all of these platforms will give you this information without a doubt. You just might have to, you've got to recall, in effect, go back to some of our early days in training where we were recalling bits and pieces of cardiopulmonary physiology to draw the conclusions that we draw and to answer each of those questions. So I think we're in much better position now than we ever have been to deploy these home sleep apnea tests in all kinds of new ways.
What is the most common cardiac abnormality associated with central sleep apnea?
So I think that there are two. Heart failure is definitely very high on the list as a cardiovascular abnormality. And then atrial fibrillation is in at least a third, if not half, of the patients with central apnea. So those are the two that we think of. And then we know that central sleep apnea can be a consequence of a stroke. So you could argue that stroke is being kind of a driver of central apnea. But in our experience and in the clinical trials, it's been both heart failure, meaning heart failure with reduced ejection fraction, and atrial fibrillation.
And I would go on to say that the vast majority of patients with heart failure or atrial fibrillation will test positive for sleep apnea. And there's strong evidence that managing the sleep apnea can improve the outcomes, the cardiovascular outcomes in both of these patient populations.
Can you provide any updates on treating central sleep apnea with ASV in cardiac patients with ejection fraction less than 45?
I think that's really a target group for the remedy system, the phrenic nerve pacing system that I've discussed. And the primary reason for that is that really effectively most other non-invasive options are off the table. For this group of patients, adaptive servo ventilation has been precluded by the FDA's black box warning of excess mortality with that therapy. The pharmacologic agents, although somewhat effective, have pro-arrhythmogenic potential, and supplemental oxygen and PAP and non-ASV PAP modalities are usually insufficient for those with moderate to severe sleep apnea. So it's really, these folks are terribly symptomatic, and as Dr. Goldberg mentioned in his first slide, that there may be multiple mechanisms for fatigue in these cardiovascular patient cohorts. But boy, with the vast majority of patients having sleep apnea, it's hands down going to be one of the major contributors of daytime fatigue in the heart failure and AFib populations.
Do you use different questionnaires for central sleep apnea and obstructive sleep apnea?
Not that I know of. Lee, have you, because I know Penn has had the program there, is there a different questionnaire per se, or are you using standard stuff to flag the possibility of sleep disorder breathing?
Yeah, we do not have separate questionnaires for central versus obstructive. Over the years, we added nocturia, and we've added atrial fibrillation to kind of our past medical history risk factors. And that seemed to pick up a larger group of patients. The AFib in particular seemed to pick up more of the central apnea patients than we had been previously, but it's all one questionnaire that's applied to all patients as they come into the practice.
Excellent. Well, I want to conclude by saying thank you to our two presenters, our sponsors, Itamar Medical and Respicardia, and to our audience members. Email me at sroy@medcore.com with comments, questions, and future webinar suggestions. Or if you watched the live event for at least 60 minutes but didn't receive or don't receive your certificate within 30 days, visit us at www.sleepreviewmag.com. Additional questions, the device-related ones, will be sent to the device manufacturers, so we may be able to get you some answers to those even after the event. And we also use your questions for story ideas for Sleep Review Magazine, so I hope everyone will subscribe. Thank you so much for participating in the Sleep Review webinar.
Thank you.